Good morning, all. Welcome to Module First. Myself, Dr. Sandeep Kumar Bains, Professor and Head, Department of Oral Medicine and Radiology, Surendra Dental College and Research Institute, will be talking about extraoral radiographic techniques. Extraoral radiographs are taken when large area of the skull or jaw must be examined or when patients are unable to open their mouths for film placement. In extraoral radiographic examination, both the X-ray source and the image receptors are placed outside the patient's mouth. The indications of extraoral radiographs are to evaluate larger area of the skulls and jaws, to evaluate growth and development, to evaluate impacted teeth, to detect diseases, lesions and condition of the jaw, to examine the extent of the large lesions, to evaluate trauma and to evaluate TMJ area. The disadvantages of extraoral radiographs are that it leads to magnification, details are not well defined in extraoral radiographs, and it has reduced contrast. Extraoral radiography projections, they are divided into radiography of the skull, radiography of the zygomatic arches, radiography of the maxillary sinuses, radiography of the mandible, radiography of the TMJ, and panoramic radiography. The equipment used is the most common skull radiographs are taken using either an isocentric skull unit such as the Orbix with patient lying down position or using craniotome with the patient standing. And this is isocentric skull unit and this is standing unit. The basic component of the craniotome are X-ray generating apparatus, that is, it is capable of producing high intensity, high penetrating X-ray beam, the step-up transformer, it is movable in vertical plane and capable of adjustable X-ray beam collimation. Counterbalance to allow easy positioning of the heavy tube head, degree scale, cassette holder, anti-scatter grid to design to stop the photons scattered within the patient from reaching the film. And this is the diagrammatic representation of extraoral radiographic unit. Skull radiographs require 20 by 25 cm or 8 by 10 inches film. For lateral oblique view of the mandible, it is sufficient to use the 13 by 18 cm or 5 by 7 inches film. It is also advisable to place L or R on the appropriate corner of the cassette to indicate the patient's left or right on the resulted radiograph. Maxillofacial of the skull projection, it comprised of posterior anterior view of the skull, rotated posterior anterior view of the skull, Cardwell view, Townes projection, true lateral projection, submentovertex view projection, lateral cephalometric projection and posterior anterior cephalometric projection. The position of the patient for skull radiography depends on the general condition of the patient, particularly following trauma, and the equipment available. With the isocentric Orbix, the patient simply remains supine and the equipment is rotated around the head to produce the required projections. Using the craniotome, the patient's head and the equipments are moved in different directions. Positioning the head is facilitated by radiographic line, which is known as radiographic baseline, which extend from the outer canthus of the eye to the external auditory meatus and is sometimes referred to as orbitometal line. And this is radiographic baseline used for taking extraoral radiographs. Coming to the first projection, that is posterior anterior view of the skull. This projection shows the skull vault, frontal bones, orbits, ethmoidal sinuses and nasal cavity. Indications are to evaluate the fracture of the skull vault, for investigation of frontal sinuses, conditions affecting the cranium like Paget disease, multiple myeloma and hyperparathyroidism and intracanal calcifications. This is the resultant image. The various landmarks seen. The patient is positioned facing the film with the head tipped forwards so that the forehead and tip of the nose touch the film, so called forehead nose position. The radiographic baseline is horizontal and at right angle to the film. This positioning level of the base of the skull and allows the vault of the skull to be viewed without superimposition. And this is placement of the cassette and patient positioning. Mid-sagittal plane is perpendicular to the cassette and to the floor. Radiographic baseline is perpendicular to the cassette. The X-ray tube head is positioned with the central ray horizontal or 0 degree to the, that is centered through the occiput. And these are the few radiographs showing rhinolith position in the nasal fossa, radiograph showing widened cranium and open fontanelle. Now coming to the rotated posterior anterior projection, This projection shows tissues of one side of the face and is used to investigate parotid gland and tremors of the mandible. Main indications are to evaluate stones and calculi in the parotid duct, to assess lesions such as cysts and tumors in the ramus, to note any mediolateral expansion, to assess subgastric infection, and to check new bone formation. This is the resultant image. Various landmarks seen. The patient is positioned facing the film with the occlusal plane horizontal and tip of the nose should touch the film so that there is a normal head position. The head is rotated 10 degrees to the side of the interest. This positioning rotates the bones of the back of the skull away from the side of the face under investigation. Central beam is directed horizontally perpendicular to the film and aimed down the side of the face. Now coming to the next projection, that is Townes view. It is also referred to as anterior-posterior projection. It clearly views occiput and the structure of the posterior cranial fossa. It also shows middle ear and mastoid ear cells. This is the resultant image and the various landmarks seen. The film is placed perpendicular to the floor in a cassette holding device. The mid-sagittal plane of the patient head is perpendicular to the floor. Canthometal line is parallel to the floor and back of the head should contact the film. The central lip beam is directed to the midline of the skull at 30 degrees to the canthometal line. Coming to the next projection, that is true lateral skull projection. This projection shows the skull vault and the facial skeleton from lateral aspect. This view is used when a single lateral view of the skull is required, but not in orthodontics or growth studies. Indications: fracture of the cranium and the cranial base, to evaluate middle third facial fractures to show possible downward, backward and displacement of the maxillae, investigation of the frontal, sphenoidal and the maxillary sinuses. Condition affecting the skull vault, such as in case of Paget disease, multiple myeloma, hyperparathyroidism. Conditions affecting the sella turcica, such as tumor of the pituitary gland in acromegaly. This is the resultant image and various landmarks seen. The patient is positioned with the head turned through 90 degrees, so the side of the face touches the film. In this position, the sagittal plane of the head is parallel to the film. The exit tube head is positioned with the central ray horizontal and perpendicular to the sagittal plane and the film, centered through the external auditory meatus. And these are a few radiographs showing increase in density and dimension between the internal and the outer cortex in patient with Paget disease, that is cotton wool appearance, is appreciable in this radiograph. Multiple circular radiolucent lesions are seen in patient with multiple myeloma. Well-defined point-out lesions in Langerhans cell histiocytosis. Air fluid level in the maxillary sinus. Now coming to the next projection, that is submentovertex view projection. This projection shows the base of the skull, the position and the orientation of the condyles, curvature of the mandible, sphenoidal sinuses, lateral wall of the maxillary sinuses, any displacement of the fractured zygomatic arch. This view will often display the medial and the lateral pterygoid plates and foramina in the base of the skull. Now coming to the indication, to evaluate distinctive expansile lesions affecting the palate, pterygoid region and the base of the skull, for investigation of the sphenoidal sinuses, assessment of the thickness of the posterior part of the mandible before osteotomy. This is the resultant image. Various landmarks seen. The cassette is placed perpendicular to the floor in a cassette holding device, head and neck extended backward as far as possible with the vertex of the skull on the center of the cassette. The mid-sagittal plane of the patient's head is perpendicular to the film and the canthometal line is kept parallel to the film. The exit tube head is aimed upwards from below the chin with the central ray at 5 degrees to the horizontal, centered on an imaginary line joining the lower first molars. The few radiographs showing thinning and bowing of the ramus in a lateral direction in patient with neurofibromatosis. Now coming to the next projection, that is jug handle view. The patient positioning and placement of the film is same as in case of the submentovertex projection. This is also known as modified submentovertex projection. This is used for evaluating zygomatic arch. Here the exposure parameters are kept at 1/3 as in case of submentovertex projection. Now this is the end of the first module. Thank you.